NHS Wellness Podcast, and today I have gastroenterologist Dr. Simpson, and he works out of the NHS GI Clinic, and we are going to talk about colon cancer awareness. Happy Colon Cancer Awareness Month. It is. So let's get started. What are some signs and symptoms of colon cancer?
There may not be any.
It's silent.
Well, it doesn't have to be, but that's the toughest thing about it is if you wait until you have symptoms, you're going to be in trouble. Many colon cancer is very symptomatic. We always get worried when anybody passes blood. One of the greatest misconceptions that I hear all the time is people will tell me, well, the blood I passed was bright red, so it's safe, and it's not. I tell people all the time, every one of us has hemorrhoids because we're born with them.
Mm-hmm.
So that means everybody who has colon cancer has hemorrhoids. You can't assume that the blood you're passing is coming from your hemorrhoids. So bleeding, a change in bowel habits. If you go all of a sudden from being constipated to having diarrhea, or the other way around, or from regular to not being regular, we pay attention to that. Pain, obviously, but by the time you have pain, you're getting in trouble probably. But really paying attention to symptoms isn't what we want to do.
Right.
This is really one of only 3 truly preventable cancers that we have. Colon cancer is 100% preventable, more than 90% preventable. Cervical cancer is preventable, and anal, but they're caused by the same thing. And then, and that's it. Breast cancer is not preventable. All of the push for mastectomy, breast self-exam, that's all geared at early detection.
Mm-hmm.
What we want to do is prevent it. And we can do that because colon cancer develops from a benign precancerous polyp. And it's been well proven that if we take those out across someone's adult life, we can reduce their risk of getting colon cancer 95% plus. So and it's not 100 because colonoscopy is not a perfect test. It's done by human beings. But we can really reduce your risk of getting colon cancer if you just get screened.
And the screening includes?
Well, there's lots of different screening regimens that have been looked at, ranging from simple blood tests on the stool to shorter scopes called sigmoidoscopies, which really nobody does anymore, to Cologuard, which is the very well marketed stool test that you can do at home. I'm not a fan of the test for lots of reasons. We can talk about that if you want, but it's not what I would recommend. But really the best is colonoscopy for a couple of reasons. It's very definitive. It's a one-stop shop. If you have polyps, we take them out right then and there. With the other test, if you have an abnormal or a positive test, you have to come back and have a colonoscopy. Mm-hmm. And it's safe. It's not uncomfortable. It's not embarrassing like a lot of people worry about. And if you're average risk and you have a normal colonoscopy, you just do it in 10 years, every 10 years, as opposed to annually or every 2 years.
Is it painful?
No, there's really no discomfort at all. The way we do it here at NHS is we use our anesthesia providers to keep people comfortable. Mm-hmm. Most people have no recollection of anything being done to them. Actually, I've had people wake up and argue with me whether we actually did something or not. The only unpleasant part is doing a prep. You have to clean the stool out of your colon so we can see what we're looking at. I've done 3 of them. It's not anything you're going to go line up to do. It's not a fun thing, but it's not bad. And it's a lot. I tell people all the time, one of my little cliches, it's a lot better than having a colostomy or getting chemotherapy.
Yeah, that makes sense.
Great.
So as nutrition-wise, is there the way we eat, does that affect?
So, the development of colon cancer is in part controllable and in part not. But by the time we get to where we're talking to folks our age, um, the impact of nutrition is not that great. Nobody's ever so nutrition is a risk factor. Cigarette smoking is a risk factor. It's going to be a nice segue into something we want to talk about too.
Yeah.
But nobody's ever been able to prove that changing what you take in your diet reduces your risk of getting polyps or cancer in the future. And my thought about that is that we're talking about changes that should be made when you're a child. And not after you've already had your first colon polyp, which is the way those studies were designed. Because at that point, a lot of the damage is done. Clearly, there's a genetic component. So people who have relatives that have colon cancer, particularly first-degree relatives, mother, father, brother, sisters, children, we see that sometimes. But still people who have second-degree relatives, like your grandparents, or people who have parents that have polyps in the past, that's the same disease, you're just interrupting it earlier. Those people are at increased risk and need to be screened earlier and more often. People who have known genetic predispositions, there's the syndromes out there, they need to be addressed differently and more aggressively. People with long-standing inflammatory bowel disease like ulcerative colitis and Crohn's disease need to be addressed differently. But the majority of the people we see are what we call sporadic, or their average risk. And really manipulating your diet is right now not going to help you. The average risk person ought to have their first colonoscopy at age 45. It used to be 50. Several years ago, we lowered that age to 45. That age is, that's now well accepted by the insurance companies. It's not a problem. And the age was lowered because we've seen a progressive trend towards younger and younger people getting colon cancer. And I'm finding polyps in people in their 20s now that are getting colonoscopies for unrelated reasons. So they have diarrhea or bleeding. So we're seeing it at a younger and younger age. The segue is that clearly obesity is a risk factor. People who are obese are at higher risk to get colon cancer. There's very good data now that shows that people who have fatty liver disease, which is something we take care of all the time, develop colon cancer at a younger age and need to be screened earlier. And my suspicion, it hadn't been documented yet, although there's a lot of data that infers it, is that that's because of insulin resistance, which is a topic I know you've talked to Dr. Myers about.
Yeah, and you're seeing a lot of insulin resistance.
We see a lot of insulin resistance patients because we take care of a lot of fatty liver disease patients. What used to be called non-alcoholic fatty liver disease. It's now metabolic derangement associated fatty liver disease. It's a more accurate term, but it's a lot more confusing to patients. But this is a disorder of excess fat deposition in the liver that's associated with inflammation. And that inflammation can lead to scarring and ultimately cirrhosis. And clearly now, fatty liver disease is one of the most common reasons for liver transplant in the United States, soon to be the #1 cause for liver transplant. It's racing past hepatitis C and really has hit epidemic proportions. There's some suggestion that 1 in 10 people have excess fat in their liver in the United States population. And it's because our population is getting heavier and heavier and heavier.
We are, I would call us a blessed population, but we can go to the nearest fast food or,
Well, our diets are not very healthy. That's a subject for a whole podcast.
Yes.
There.
I want you to touch on it
I
though.
will. And we're not physically active. We're very sedentary. And you'd be amazed, it really doesn't take that much to make a difference. We carry around too much weight. We eat a diet that is very rich in carbohydrates and has a very high sugar content. This all kind of dates back to, unfortunately, when I was in medical school, which ages me. The guys at UT Southwestern in Dallas discovered that the plaques that make up coronary artery disease are made up of cholesterol.
Mm-hmm.
So the federal government decided that if cholesterol is hurting people, then cholesterol must be bad for you. And they came out with the food pyramid, which we all see in school, that has very little fat at the top and lots of whole grains and complex carbohydrates at the bottom, which is supposed to be the major component of your diet. And it turns out it's completely wrong. And eating that diet actually drives your cholesterol up. It causes your insulin level to stay high, which pushes carbohydrates into fat. It pushes fat into your fat cells, worsens atherosclerosis, leads to fatty liver disease. So there's a syndrome called the metabolic syndrome, which consists of high blood pressure, high cholesterol or high fats, type 2 diabetes, and fatty liver disease that develop in the face of obesity. And that's all from insulin resistance. It can be cured. It's just a very difficult thing to get people to wrap their head around the fact that they can cure this. But this is very rapidly becoming probably the number 2 cause of liver disease in the United States, with alcohol overuse being number 1 still.
As far as fatty liver.
Just period. Liver disease.
Liver disease.
Yeah, altogether.
So alcohol and nutrition.
And then fat.
Eating or not eating. Do you eat fat?
I eat a ton of fat.
Well, you lost a lot of weight. I mean, we noticed that.
So my diet is, and I kind of try to hold it out to people as an example. I was borderline, kind of on the cusp of becoming a type 2 diabetic, and my dad was heavy and unhealthy, and I always told myself I wouldn't do that. And so I kind of radically changed how I approached my diet, and I've always exercised. And I can understand now why people get frustrated because they don't lose weight. Because exercise is important, but how you eat and what you eat is much more important. You can overcome the effect of exercise. So I eat. I'm not quite as radical about my diet as my colleague Jack Myers is, although he's been a big help to me and helped me care for my patients. I eat meat. I don't mind fatty meats, but I eat salads and leafy green vegetables, a few cruciferous vegetables like carrots. I just stay away from starchy fats. I tell patients all the time, white foods are bad for you.
White foods are bad.
If it's white, don't eat it.
Right.
And that doesn't mean that I don't treat myself every now and then. And I grew up in the South, and so, like, my wife made homemade cream corn the other night. There's no way I wasn't going to eat some of it. But the next morning, I'm right back where I need to be. So, patients don't understand that there's a balance between not punishing yourself, but not saying, oh, well, I can have a little bit of this, and then talking yourself into having a little bit more and a little bit more and a little bit more. But overall, it's meat, no fear of fat, leafy green vegetables.
And that's good for the digestive tract.
It's great for your gut. Yeah.
Even the leafy green vegetables.
Yep. Yeah, green vegetables are wonderful things, except maybe peas. Peas are a little starchy.
They're a little gross. They're gross.
But I think if we kind of got a little bit off track. If people will take away from what we use March to remind them, really, virtually nobody in the United States should die of colon cancer anymore. But unfortunately, it's the number 2 or number 3 cause of colon cancer death in the United States. Lung cancer is falling. It's right there with breast cancer. So get screened.
Get screened. So do they have to have a referral to make an
No.
appointment with you? So you can just call the clinic and make an appointment to get screened.
Hmm.
Well, I thank you.
My pleasure.